Hello, welcome to the SAMHSA webinar, Strategies to Address the Opioid Epidemic in Black and Hispanic Latino Communities. Please note that all participant lines will be muted during the webinar. The webinar will also be recorded. Should you have any questions during the webinar, please send questions through the Q&A located at the bottom of your screen. We will make every attempt to answer all the questions during the webinar. Should you have any technical issues, please contact Amy Rabin at 202-486-3875 or arabin@capconcorp.com. That's also in the chat section. You can pick up the email. One last comment, once the webinar is ended, a feedback form will pop up on your screen. We would truly appreciate your feedback on this event. Thank you in advance for your time and effort. And now I'd like to turn this webinar over to today's facilitator, Dr. Lark Hwang, Director of SAMHSA's Office of Behavioral Health, Equality, and Justice Involved. Thank you.
The Behavioral Health Committee and SAMHSA. I'm pleased to welcome you to this webinar on strategies to address the opioid epidemic in Black, African American, and Hispanic Latino communities. The opioid epidemic is a high priority of our agency and the Department of Health and Human Services, as it is around the country, with about 130 people dying each day due to an opioid-related overdose. The epidemic has garnered nationwide attention, generated significant federal and state funding for prevention and treatment, and has shaped the priorities of many local communities. What we hear less about, however, is how this epidemic is playing out in African American and Latino communities. This is the focus of this webinar. Specifically, our objectives are to understand the epidemic as experienced by these historically underserved populations, to highlight prevention, engagement, and recovery strategies that are embraced or developed by these communities and taken into consideration community context, and to show how these strategies, in conjunction with established evidence-based treatment, have the best potential for preventing and reducing the impact of opioid misuse. We have a stellar cast of presenters who are working in Latino and African American communities using critically important and innovative strategies to address this issue. I will introduce them as they each present. I want to begin, however, with a quick overview of the epidemic in terms of some national data. Next slide. Next slide. Jen, next slide. Okay, these are our presenters for the webinar, and I will introduce them in more detail as they present. Next slide. Okay. In 2017, the administration declared the opioid epidemic a national public health emergency. The Department of Health and Human Services developed a 5-point strategy to combat the opioid crisis, including 5 components. These components include access to better prevention, treatment, and recovery services, better data on the epidemic, better pain management, 4th, better targeting of overdose reversing drugs. 5th, better research on pain and addiction. In considering the 5-point strategy, we're interested in how it has played out and how is it addressing the crisis and relevant to the African American and Latino communities, and this is some of what you will hear today. Next slide. The second point of this 5-point strategy includes a focus on better data. I want to share with you some critical data points. They're on this slide. You'll see SAMHSA's National Survey of Drug Use of Health just recently released their 2018 report showing that 10.3 million people misused opioids in 2018, which is lower than the 11.4 million that misused in 2017. So we see a positive trend there. Additionally, opioid use disorder decreased to 2.2 million people with an opioid use disorder from 2.1 million in 2017. Our focus is also on opioid-related overdose deaths, and the most recent data from CDC in 2017 showed there were 70,000 drug overdose deaths in 2017 in the U.S. 68% of the deaths were from opioid-related overdose deaths. That equates to about 47,000 opioid-related deaths in 2017, which is 6 times higher than what it was in 1999. Fentanyl overdose deaths, those involving synthetic opioids other than methadone, have also sharply risen from 2013 to 2017 and is of increasing concern. Next slide. This slide moves into drug overdose death rates data by race and ethnicity. While rates for all groups have increased, African Americans has a 40% increase in overdose death rates from 2015 to 2016, which is the highest magnitude increase compared to all other racial ethnic populations and when all race ethnicities are combined. So that is a particular concern. Next slide. This slide captures opioid misuse by race and ethnicity. In 2017 and 2018, about 4% of each population, non-Hispanic Black, Hispanic, and the national total population, had opioid misuse in the past year. It was estimated that in 2017, 97% or more of each population's opioid misuse was from prescription opioid misuse. Next slide. This slide captures the death rates by race, opioid overdose death rates by race and ethnicity. You'll see the top of the slide shows the death rate per 100,000 people, 12.9 for the African American population, 6.8 for Hispanic, the national rate 14.9 per 100,000 population. But when we look at overdoses with synthetic opioids, the rate of increase is greatest among the Black and the Hispanic population. It's critical to use this data to learn how the opioid epidemic is affecting different racial, ethnic groups, and is foundational to being able to provide access and services to these often underserved populations. Next slide. This slide, these graphs are showing specifically the increase or change in death rate, not the absolute death rates, of the opioid drugs listed in the graph for Black, non-Hispanics in 2014. Heroin and prescription opioids were the opioid drug with the highest death rate, each at 2.5 deaths per 100,000. In 2016, it changed to synthetic opioids other than methadone as the highest contributed to the death rate at 5.6 deaths per 100,000. We see a similar pattern in Hispanic population, so we see the role that synthetic opioids are playing in the overdose death rate, particularly for these two populations. You can see the blue bars in each, which represents the death rate by synthetic opioids other than methadone. Next slide. This slide is a picture of state opioid overdeath rates in 2017. We included this just so you could get a sense of what's happening in different states across the country. The map on the far left also shows the Department of Health and Human Services, the federal government regions of the country, how they're divided up into states into different regions. And the gray states are states where there's insufficient data, or they don't report the data, or the data is not broken out by race and ethnicity. You can see the Midwest, Mid-Atlantic, Northeast, and a state or so in the Southwest have the highest overdose death rates for these populations, but it also varies by which population. Next slide. The top 5 states with the highest opioid overdose death rate for each of the 3 populations are shown on this slide. When we look at opioid overdose death rates by state data, these rates are especially high for both Black, non-Hispanic, and Hispanic populations. Most striking, though, is the African American population. For example, District of Columbia and West Virginia both have opioid overdose overdose death rates for 2017 that are highest in the state's population death rate. It's important to see that also when you look at that for the highest states with the death rates for African Americans, they're even higher than the states with the highest death rates. It's a bit of a confusing slide, but we wanted to also convey that it's important to look at what's happening in individual states and with individual populations within those states to really know what's going on in one's community. Next slide. To learn more about the opioid epidemic in the African American and Latino populations, we conducted here at SAMHSA a number of interviews with community leaders, community experts, people with lived experience, program directors working specifically in these communities to learn more. These are some of the barriers to prevention and treatment that we learned about. First, history matters. Many communities of color are still concerned that the war on drugs will repeat itself. This was a criminalizing of addiction and people with substance use disorders, leading to incarceration and lengthy prison sentences. Secondly, a fear of seeking treatment. It's pervasive in many of these communities. Concerns about deportation in the Hispanic community, fears of incarceration or losing one's children to child welfare in the African American community if they seek treatment. We still see many misperceptions about addiction. Still, some see it as a moral failing, a criminal behavior, not as a disease that needs treatment. We still see separate and unequal pathways to prevention and treatment. Messages regarding substance use and addiction are not easily uncoupled from disinvestment in communities of color, over-policing, over-incarceration, over-traumatizing, and the need to frame a prevention message that must resonate with the community. Similarly, we see unequal access to treatment or unequal treatment being the standard of care. For many Black or Hispanic communities, there is significant variation in who can readily access buprenorphine, for example, versus methadone treatment. We are told repeatedly of a racialized drug policy and treatment stratification, where oftentimes methadone clinics are for urban people of color and buprenorphine is via private physicians and health professionals for suburban white people. We also see that and heard that people of color are often doubly jeopardized by their minority status and their addiction, and that attention to cultural and linguistic issues in care for these populations are critical. Creating respectful engagement in care is equally essential, and you will hear how some of this has been done in some of the following presentations. And finally, as we talk with people living in these communities or working in these communities, there are quotes and themes that we want to share with you from our conversations. We heard that, quote, many don't understand how addiction works, don't understand that it is an illness, not a crime or moral failing. And we heard about the need to create safe healing spaces, acknowledge past harmful efforts, discuss the evolution from the war on drugs to a public health emergency. We heard addiction is beyond the neuroreceptor level, that a comprehensive approach that addresses social determinants of health is indicated, that medication-assisted treatment is the evidence-based practice. It may be necessary, but not sufficient alone, that we need to mobilize communities and families. Community partnerships are critical, and you'll hear about how these are done today as well. Another theme was the dual mission of the church, meeting social and spiritual needs to promote health and healing, the importance of engaging churches, faith leaders, and traditional healers. The faith-based community is often the default in communities of color, yet it must be customized, and we must acknowledge the diverse strategies used by faith communities, which you will also hear about. We heard that the opposite of addiction is not abstinence, it's connection, that we must value trusted messengers and community residents, peer specialists, peers in recovery, promoters, community health workers, and other ways to get messages about prevention and treatment out. We heard that engagement is a connection with the individual and the community is essential in order for the evidence-based practices to have an impact. We need to identify communities' trusted first responders. So if we're distributing overdose reversal drugs through law enforcement, we must recognize that law enforcement is not always the trusted messenger or the trusted entity in many of these communities. And finally, we learned that oftentimes public awareness campaigns are whitewashed and make no sense in the Black community or the Latino community. We must develop campaigns that reflect the population and are culturally and linguistically on message and use trusted messengers. Much of this information we'll be pulling together in an issue brief to be released later this fall. Now I want to go to our four speakers to share their strategies to address the opioid epidemic and the work that they've been doing in their communities. I want to start first with Dr. Ricardo Cruz. He's a primary care physician at Boston Medical Center. His focus is on providing primary care and treatment for substance use disorders for underserved populations, particularly Latinos and those with criminal justice involvement. And he is the principal investigator on Project Recover. Dr. Cruz?
Hi, thank you for that kind of introduction, Dr. Wong. And thank you for the opportunity to talk about Project Recover here at Boston Medical Center. Next slide. So according to the Massachusetts Department of Public Health Bureau of Substance Addiction Services, in 2016, approximately 74% of acute treatment services or detox admissions were for opioids, the vast majority with the primary drug being heroin and a small proportion for other opioids. Treatment data suggests that people with an opioid use disorder do not have continuity in substance use treatment. According to a 2015 study of 485 people at the time of acute treatment services admission, 96% were interested in further treatment, with the largest proportion being interested in office-based services such as buprenorphine or methadone maintenance. Despite near universal preference for treatment, studies have found that 67% of these individuals fail to engage in treatment. Studies show that approximately 90% of these individuals eventually relapse within a year after discharge from acute treatment services. Here at Boston Medical Center, there's been a long history of innovative programs to assist with engagement, treatment, and recovery efforts for individuals with opioid use disorder, including our Office-Based Addiction Treatment Program, or OBOT, which is a nursing-led program that supports providers in initiating and engaging in individuals with opioid use disorder in treatment. We have a Faster Pass Clinic, or Opioid Urgent Care, to provide low-barrier access to medications and connections to longer-term treatment options. In addition to that, we have a program called Project Assert, which is an ER-based initiative to assess and refer people with substance use disorders to appropriate level of care. Often they're referred to acute treatment services from the emergency room. And then recently, Boston Medical Center was awarded a Healing Communities grant from the National Institute of Drug Abuse to lead a research study with the goal of reducing opioid deaths by 40% in some of the most heavily impacted Massachusetts communities. Next slide. So focusing on our Hispanic and Black communities here in Massachusetts. So in Massachusetts, we're able to break down the opioid-related mortality data by race and ethnicity, and we are seeing some concerning trends, as prefaced by Dr. Wong. According to CDC, in 2015, Massachusetts had the fourth highest opioid-related mortality for Hispanics in the nation, and just according to Dr. Wong's prior slides, we seem to be at number one at this moment. From 2014 to 2017, we saw a large increase in the opioid mortality rate among Hispanics, which increased from 16 to 31 persons per 100,000 residents. And during the same time period, Black non-Hispanic opioid mortality rate also increased from 11 to 20 persons per 100,000. The 2018 data does show a leveling off and decline, so we're hoping that some of the new strategies implemented in the communities are having an impact with these populations. Next slide. In 2017, Project Recover was funded by the Office of Minority Health, Health and Human Services under the Empowered Communities for a Healthier Nation initiative, with the goal of addressing the increasing number of overdose deaths, particularly in minority communities. Through our work on the grant and the data just discussed, it was apparent that the transition from acute treatment services was an opportunity to address low engagement and further treatment, and to start to explore ways to address disparities and findings, such as those that were confirmed on a study that was published earlier this year, showing that white patients with opioid use disorder were 35 times more likely to get a buprenorphine-related clinic visit than Black patients. Project Recover stands for Referral, Engagement, Coaching, Overdose Prevention, Education, and Recovery, and it aims to link, engage, and retain individuals with opioid use disorder in substance use treatment, primary care services, and harm reduction for 6 months. We use culturally and linguistically diverse recovery coaches who are experientially qualified to support their peers. Some evidence on peer recovery coaching shows potential for reduced substance use and relapse rates for individuals who utilize recovery coaches, improve relationships with treatment providers and social supports, and increase treatment retention and satisfaction. Our recovery coaches work to develop recovery wellness plans with participants to address perceived barriers to recovery, including social determinants of health. Next slide. So here's an example of a recovery wellness plan that is created by the recovery coach working closely with the participants. Recovery wellness plans are created to develop and address key values of achieving recovery. They assist in achieving hope, personal empowerment, education, self-advocacy, and support with ultimate goal of improving quality of life and achieving one's own goals for recovery. The 8 domains listed here include connection to the recovery community, physical health, emotional health, spiritual health, living accommodations, job and education, personal daily living management, and anything else that the recovery finds important and would like to focus on towards recovery. Next slide. So some outcomes. Over the first 9 months of project implementation, our recovery coaches have enrolled 91 individuals. You can see from our chart, we have been successful in engaging racial and ethnic minority participants, with over 50% coming from Black and Hispanic communities. Housing instability is a significant issue with our participants, as well as a large proportion of participants have had a history of criminal justice involvement, which we know directly impacts social determinants of health downstream. Next slide. Thus far, some outcomes from our project include of those individuals that we've been able to contact at 1 month, 86% have been engaged in treatment with medications. 76% of these participants, in addition to 43% of participants' social network, have received in-depth overdose prevention education, and in many cases have received naloxone rescue kits. We've seen a good proportion of people that have engaged with primary care services. And of the 91 participants thus far who've had contacts at various points, we've only had 9 non-fatal overdoses reported to date. Next slide. So some key lessons thus far being 9 months implemented. We've been fortunate enough to have a recovery coach supervisor that supervises our 2 recovery coach. And I think this is key to having a successful recovery coach program. They provide coaches with support and a venue to discuss complex cases that may arise while they do their work. Recovery coach development is also an important aspect in having a successful recovery coach program. We provide additional training to help coaches develop additional skills to be able to support the participants. In addition to support themselves, we offer them trauma-informed care training, which will allow them to address any secondary trauma that they may receive working with these complex individuals. The recovery coach model we see is very flexible. It's not tied to a specific location. They're able to meet the participants where they are in the community. This allows for flexibility and also allows for some navigation as needed to help participants navigate through the complex treatment system. In addition, using culturally and linguistically diverse coaches are key. According to medical literature, there's evidence that cultural and linguistic concordance is key in treatment adherence, and we find that concordance is also key in engagement and retention of minority populations. And then also addressing social determinants of health to prioritize by the recovery or participants, as covered in the Recovery Wellness Plan, allows for participants to take control of their path to recovery. Some challenges that we've seen thus far from our project is just the transiency of the population. As I mentioned before, a lot of our participants do struggle with housing insecurity, and then also being criminally justice involved, which makes it difficult for our coaches to, remain in contact with individuals. And in addition to that, and they're difficult to track, we've had high attrition rates, and often individuals don't have means to be able to contact our coaches or our coaches to be able to contact them. Next slide. So other strategies that we'll be doing in Project Recovery are conducting key qualitative informant interviews with Black and Hispanic participants with opioid use disorder. This will give us an opportunity to better understand barriers in accessing or receiving treatment, and then getting a sense of how our recovery coaches are providing or assisting with the recovery process and potentially advocating and addressing any racial inequities while they receive treatment. Our recovery coaches have been involved statewide in the ongoing process improvement for the recovery coaches initiative here in the state of Massachusetts, and they've been involved in conversations about potential reimbursement for this workforce. Next slide. So some take-home messages from our project is peer recovery coaches could potentially be a promising model to address some of the barriers faced in the path to recovery by minority communities. Community-led and community-centered approaches are essential to successful engagement in minority communities with opioid use disorder. Collaboration with community organizations is key. Our recovery coaches have done an excellent job doing outreach with community organizations, and it provides them with a list of resources that they will be able to offer the participants that work with them. And then there's obviously a need to address disparities by addressing root causes of, including criminalization of addiction, social determinants of health that often disproportionately impact minority communities. Thank you.
Thank you very much, Dr. Cruz. I want to move on to introduce Dr. Pierluigi Mancini. Dr. Mancini is the Project Director for SAMHSA's National Hispanic and Latino Addiction Technology Transfer Center, as well as the Prevention Technology Transfer Center, which are both housed at the National Latino Behavioral Health Association. He will be speaking about his work as a founder and former CEO of Clinic for Education, Treatment, and Prevention Services, which focused on treatment and prevention of substance use that work with the Latino population. Pierluigi?
Thank you, Dr. Juan. I bring you greetings from the National Latino Behavioral Health Association and thank SAMHSA for highlighting this very important topic. It is a pleasure to be here with you today. Today, I'll be talking to you primarily about my work in my previous role as founder and CEO of Georgia's only Latino Behavioral Health Association in Atlanta. Next slide. For the Latino community, it is a public health problem. We have rising rates of illicit drug use among Hispanic and Latino youth, including opioid use. As has been mentioned, in 2017, SAMHSA's National Survey on Drug Use and Health noted a rise in the lifetime illicit drug use among Latino Hispanic youth aged 12 to 17 and 18 to 25 from the previous year. Also, the National Youth Risk Behavior Survey found that, compared to other racial and ethnic groups, Latino students in grades 9 to 12 reported higher rates of opioid use. Latino students reported higher rates of heroin use compared to whites and were exceeded only by Black male students regarding the prevalence of injecting some illegal drugs. In addition, the prevalence of having even ever taken prescription pain medications such as oxycodone and hydrocodone without a prescription or against medical advice is generally higher among Latino students than among white and Black students. And the fatalities of members of the Latino community have increased as it's been. Next slide. I will be presenting a prevention and a treatment strategy. This is the prevention strategy. The goal of the strategy was to reduce prescription drug abuse among 12 to 15-year-olds in Gwinnett County, Georgia. The specific issues of this campaign were the improper storage of safe disposal of prescription medication and the low perception of risk. Both items were identified through the needs assessment performed as part of the strategic prevention framework. Next slide. Because the Hispanic community was at such low awareness, it was decided that the designing strategies to intentionally overlap would create maximum impact. For the Perception of Risk Awareness campaign, we created a public service announcement for movie theaters. The PSAs would run before the movie previews. Our social access awareness campaign included a media campaign and educational interventions at Hispanic community activities, such as health fairs and parent workshop presentations. The media campaign included billboards in Spanish, newspaper advertisement running in Hispanic publications, as well as radio PSAs and interviews airing on Hispanic radio stations. And our pharmacy bag campaign consisted of providing pharmacy bags to pharmacies with printed information on safe disposal and the dangers of prescription medication. It also included a website link so the individuals could find the closest drop box to them to dispose of their unused and expired medication. Next slide. The Perception of Risk campaign focused on educating the community about misuse of prescription pain pills among youth. We created a PSA that we used in movie theaters. The 15-second PSA highlighted the facts, and it was meant to be informational and invited the audience to look up their prescription medication. We partnered with Fandango, the movie theater ticket purchase company, and offered a movie ticket discount if you texted a code that we put on the screen at the end of the PSA. You'll see there is a link for the PSA if you have an opportunity to go see it. Next slide. The second part of our prevention strategy was the social awareness campaign. Part of the social awareness campaign included doing community outreach to educate on prescription opioid misuse. On the right is a picture of one of the billboards, and there are some pictures of community events. Next slide. These images show educational materials we used as part of the media campaign, which was a part of the social awareness campaign. On the left is a sample of the Spanish language newspaper ad, and on the right, it shows two billboards we used to educate the Latino community. Next slide. This slide shows what the opioid education messaging looks on the pharmacy bags for our pharmacy bag campaign. On the left is a picture of one of the designs of the pharmacy bags in English and Spanish. The acceptance levels from pharmacies varied. Some were welcoming and others did not want to participate. A few asked us to come back and eventually join the project. Next slide. The prevention strategy outcomes from this campaign for last year included: the pharmacy bag message has been translated into 6 different languages, and 22 pharmacies are participating in the program. 118,000 bags were distributed last year. 107 families attended the parent presentations. And the media campaign estimates that it reached a total of 2 million people through radio, billboards, television, and newspapers. All of these efforts helped move the Latino community in Gwinnett County from a community readiness of level 1, which means no awareness, to a level 3 in 3 years. The community readiness model was developed at the Tri-Ethnic Center to assess how ready a community is to address an issue. Stage 1 means no awareness. The community has no knowledge about local efforts addressing the issue. Stage 2 is denial and resistance. There may be some leadership in the community, and they may believe there is a problem, but there is no concern yet. They still don't know how to address it. And then stage 3 is when they have a vague awareness, but they begin to organize, and they believe to have some limited resources to put into action so they can address the issue. We were able to bring the community to a point where they now are meeting and having pre-planning in order to take some action. Next slide. SAMHSA's treatment strategy was to provide affordable, cultural, and linguistically appropriate services for Latinos with limited English proficiency, experiencing substance use disorder and mental illness through multiple activities. This included recruiting and training multilingual behavioral health staff at the clinic. We built our clinic workforce by creating internships, practicums, and residency opportunities for bilingual, bicultural, emerging and early career professionals in the behavioral health field. We felt it was important to have services provided in the language that individuals who came to see us preferred to speak. Some agencies don't have or can't find bilingual staff and rely on interpreters. We must insist that agencies use properly trained interpreters. We also knew that to fulfill our mission, we had to implement new organizational policies, which included integrating the national class standards into our clinic practices, using telecounseling and offering flexible operating hours to accommodate the client population. Next slide. By the time I stepped down from SETPA in 2016, we were seeing 150 individuals per day providing clinical services in English, Spanish, and Portuguese to children, adolescents, and adults through the entire spectrum of behavioral health. Our clinical staff grew from 6 to 41 licensed clinicians in 5 years. We had opened prevention programs in 5 cities. We opened the telecounseling program, and we kept continuous state license and national CARF accreditation with exemplary mention. Next slide. Some of the lessons learned: if another community would like to replicate this strategy, I would recommend involving the community from the beginning and being patient. You may face many roadblocks and resistance. Our community helped in develop every campaign, including our public service announcements and our documentaries, which won 6 Emmys, by the way. It is a key to conduct a community needs assessment. Also, it is important to find key community partners and business partners and to collaborate. Recruiting bilingual staff with the potential to become bilingual certified prevention specialists and clinicians is key. Sometimes people haven't thought about these professions, but they exist. They're out there in the Latino community, and we need to sometimes help them understand that these are very viable professions, and they just have not had the opportunity to be exposed to them. So we need to look beyond universities. We need to look into the community to help people think about our profession. Promoting community education that is translated into other languages is also critical in serving the Latino community. And also it is important for the behavioral health field to adapt or develop evidence-based practices and promising practices that work for Hispanic Latino communities. Next slide. And as a take-home message, I would like to say that we have a very large number of Latinos that for many reasons are not accessing treatment. One reason that is fixable is limited English proficiency. We can take care of this. We can help organizations become cultural and linguistically sound, and we can build the bilingual workforce to serve these individuals. At the National Hispanic and Latino ATTC and PTTC, we're focusing on some of these issues, including workforce development, linguistic access, evidence-based and promising practices, our leadership curriculum, meeting with Latino behavioral health and other health organizations, planning a national Latino behavioral health conference for 2020, and many other things that we invite you to stay tuned for. Next slide. I'm at your service. Thank you very much.
Thank you very much, Pierluigi. I'm going to move us on now to our next presenter, and that's Dr. Mary Langley, who is at the Morehouse School of Medicine. She's the director of the Health Promotion Resource Center, and she is principal investigator of a federally funded project, the Doherty Alliance for the Prevention of Opioid Use Disorders in Georgia. This focuses on opioid misuse among African Americans in a micropolitan and rural area. Dr. Langley, you're up.
Thank you for the opportunity this afternoon to talk a little bit about our project, which is called the Doherty Alliance for the Prevention of Opioid Use Disorder. This is a 3-year prevention grant that Morehouse School of Medicine received from the Office of Minority Health to address the opiate misuse problem among African Americans. Next slide, please. The Alliance is a collaborative of both government and non-governmental agencies, which consists of school system, law enforcement, judicial system, the coroner's office, healthcare providers, substance abuse providers, university representatives, and other community-based organizations. The purpose of the grant is to prevent opiate misuse and increase the access to treatment and recovery services in this micropolitan community. The project is located in Doherty County, Georgia, and the target population is African Americans. Drug overdose deaths in Doherty County are increasing, and it's mirroring the state and national data. But in 2010, there were no opiate overdose deaths in Doherty County. But in 2016, there were 5. Another indicator that that is a crisis emerging is that the increase of ER visits for drug-related overdoses, including heroin and prescription drugs. These visits, ER visits, quadruple for both adults and youth. Next slide, please. Some demographics of Doherty County is noted on the slide. Doherty County is located in southwest Georgia, and Georgia is in the Bible Belt, and religion and religious institutions, especially among African Americans, of cultural importance. Although categorized as a small metropolitan county, it is more micropolitan because it is surrounded by rural communities with limited resources. If you look on the slide, you see that the population of Doherty County is a little over 91,000. It has a large percentage of African Americans, almost 71%, and it has a high poverty rate, which is over twice the state rate, which is at a little over 28%. In Albany, Georgia, which is the only city in Doherty County, the population is over 77,000, and the African American percentage is over 73% with a high poverty rate. The goals of our project, our prevention project, are to reduce opiate misuse and abuse in the target community, increase treatment capacity for opiate abuse and overdose in the target community, and increase utilization of services for treatment of substance abuse, including opiate use disorders in the target community. During this short presentation, I will only address 2 of our primary objectives, which are to lower teen rate of prescription pain pill misuse and increase the utilization of substance abuse services for the African American men and women. Next slide, please. We will talk briefly about one of our strategies, which is provide opiate education, and 3 of our activities include student assembly, interactive training, and support of clergy. Next slide, please. You see a picture of one of our student assemblies. During a student assembly, presentations are made on what are opiates and the dangers of using unauthorized prescription drugs or sharing authorized drugs. Most of these drugs the students get from home, from medications that's not secured by the family. We also include our partners in our presentation, especially the police partner and law enforcement partners and our substance abuse treatment partners. Before presenting the educational information, we conduct a large-scale pre-test to assess baseline knowledge and attitudes before the presentation, and we also repeat the test at the end of the presentation. Next slide, please. One of our major events to engage our young people, our teens, is our reenactment of an opiate overdose death. You see on this screen is the Albany Civic Center. This is the second year that we have conducted this reenactment. In 2019, over 2,500 teenagers from both public and private high schools attended the reenactment. Our partners, the Dougherty County Coroner Office, the Police Department, the EMS system, and the school system participated in this enactment. It starts off with a party. One of the teens overdosed. The EMTs conduct CPR. The police department does an investigation. The coroner comes in and announces that the teen is dead, and then a local funeral home sends a hearse that's driven into the Civic Center, and the body is taken away. After the reenactment, we have speakers, and I think one of the speakers that is most touching for the student is a parent that talks about the loss of a son to opiate overdose. Another interactive educational session is at a smaller scale with our teens that we use the evidence-based curriculum, Too Good for Drugs in high school, at the alternative school to talk about not only opiate but other drug problems among teens and how to not, and the stages of addiction and the risk of associating with experimentation. Next slide, please. We also have community and partner training. On the slide, you see 3 of the ones that we have. One is entitled Community Level Solutions for the Opioid Crisis. This was conducted in our first year of the grant, and we had representatives from about 50 participants, and it was a diverse representative of community professionals, including public health nurses, behavioral health professionals, teen health professionals, law enforcement, physicians, and the Dougherty school system. We also have representation from the faith-based community and other nonprofit community organizations. Our second training, you see narcan training for first responders and other partners. This was conducted by the EMS system. It was developed by the EMTs, and we had attending this training law enforcement, Dougherty County Sheriff and the Police Department, the Dougherty County Gang Task Force, and the Albany Dougherty Drug Unit. This training is important because the grant will be providing funding for Narcan for first responders. The last training you see on the screen, Opiate Education and Community Partnership. We were invited by the Albany University, to participate in a panel for their faculty to talk about the opiate crisis and how it affects their students. Next slide, please. This is an important collaboration with the clergy, because of the dichotomous mission of the African American church, spiritual and social, that we know that if we want to reach our community, we must make a major effort to bring in the leadership of the African American church. The black church is the premier cultural institution in the African American community. Historically, the church has been the catalyst for social justice and change in this community. The involvement of the African American church in social political issues is key to our success for community outreach and information dissemination to address the emerging opiate crisis in the African American community. Why do we want to get the church involved? We want to increase the community awareness and knowledge beyond the pews. We want to recruit volunteers in our community outreach efforts. We want the pastors to incorporate the message of the opioid crisis in their messages from the pulpit. We want to increase the participation in treatment programs, and this will happen if the message from the church destigmatize addiction. We want them to become a member of the Alliance for Sustainability, and last but not least, we want the churches to open their doors to host support groups, recovery support groups. Next slide, please. We've learned some valuable lessons during these 2 years. We learned to include the target population in our community work up front. One of the important things that most programs will have community outreach workers, but we found that we need community outreach staff at the management stage. So we have not only a program coordinator, we have a community liaison coordinator whose responsibility is to oversee the community outreach efforts. We conduct a community readiness survey first. This may cause you to change your timeline, but it's important. Our community readiness showed that we were at a 3 at a vague awareness, and we're hoping with all of our outreach efforts that we'll go to at least a 7 for stabilization. Be adaptable to move community engaged work forward. You have to be adaptable to move it forward. If you want to work partner especially with the faith community, you know it's not an overnight effort. It's a process that takes time in developing relationships. It's also important who you use on your staff to engage the faith community. A pastor once told me that that the person that comes to deal with them must be churched or know what to say and how to say it. Partnering and collaboration are key in this effort, and sometimes collaboration means that you would have to do things outside of what's written in your grant, but it's worthwhile because you will build relationships. And also use strength-based framing. Value the community expertise. Learn how to listen to the community, and also know that that every community has resources. And next slide, please. Our next steps is evaluation and dissemination of results as we enter into the 3rd year and final year of our project. Next slide, please. Next slide, please. Evaluation. During the 2 years, we have conducted formative and process evaluation. During the 3rd year and after we will be focusing on outcome evaluation. What we found that help us to know whether or not we are moving in the right direction is focus group and interviewing of our key stakeholders to make sure that we are not doing anything that's not acceptable by the community. The assessment of our partnerships and community outreach. We assess our partnership if our partners will re-sign a memorandum of understanding and the number of outreach efforts that we conduct and the participants that we reach. We also have shown evaluating our success because our treatment providers are now assembling collaborative outreach teams, which includes members from the community to help screen to reach individuals to our treatment program. And that was one of our goals, is to increase African American participation in our treatment program. Next slide, please. Dissemination of results. You need to be sharing our progress and effectiveness of our project locally through social media and local newspapers. We've had several articles in the local newspaper. We made presentations locally, statewide, and hopefully we will be submitting for presentation nationally. We've created fact sheets and brochures, and we update them as we have information about the changes we are making. We promote collaborative. We promote the local collaborative and our partners. Morehouse School of Medicine is 3 hours away from Albany, so it's important that the face of the project be the face of people that live in the community. And we are preparing manuscripts for peer-reviewed journals so that we can share our journey in this effort. Next slide, please. Replication of our project. I have several things that, as I thought about replication of a project, build a strong, diverse collaborative. We had a lot of key stakeholders that serve on a collaborative, but we must make sure that we have representation from the target community. Create a community advisory group. The collaborative only meets quarterly, but the community advisory group works closely with the staff and meets monthly to provide advice and to also provide resources for many of the initiatives that we have. Form a youth leadership council. That is important. If one of our goals is to address the youth, we must have input from the youth. And I can't say it more than over and over again, conduct a community readiness assessment to make sure that you're on the line with what the community needs, and also to, if you do it annually, you can share progress, because outcome data is at the end, and it takes, as you know, 2 or 3 years to make any kind of impact change. Engage the black community in the initiative and do it at the beginning. You need the leadership of the black church to reach the target population. Do not compete with existing providers. You have to make sure that they don't think that you're bringing in this grant funding, that you're competing with them. You want to not compete but complement, and set realistic goals. We've had to revise our goals based on our progress and things that we are doing in the community. And one of the things I really want to share the funding with the partners. A lot of time we want a lot of in-kind, but sharing resources and also the money helped us a lot in developing our partnership. And last but not least, cultural competence is important. I work on, it's important just because you may be of the same ethnic group of the target population, you may not be culturally competent to reach with, to work with this community. I use the model that's developed by Dr. Edwin Nichols, which is the philosophical aspect of cultural differences. And one of the things it says that you must understand the value system of African American. It's member to member, that the highest value lies in interpersonal relationship. So if you want to work with this community, there must be trust. And this community also learns through imagery and pattern recognition. And that's why the reenactment has been so effective in reaching our target community, especially the teenagers. Storytelling is very important in this community. Last, in closing, if I had to pick 3 key recommendations for replication, I would select: build a diverse collaborative that is inclusive of the target community, involve the faith community at the beginning, and have representation at the leadership level. And last but not least, share resources and do not engage the community with, I know what you need to be saved from your problem. Thank you.
Center, thank you, Dr. Langley. Our final presenter is Mr. Andre Johnson. He is President and CEO of the Detroit Recovery Project, a nonprofit multi-service agency providing a wide spectrum of services to the city's recovery community with a particular focus on the African American community. Mr. Johnson's development of a wide array of collaborations, university, state, county, community, which you will hear about, has enabled his organization to continue to expand and provide innovative services to the Detroit community. Mr. Johnson also served as an appointed member of SAMHSA's Center for Substance Abuse Treatment National Advisory Council. Mr. Johnson?
It looks like his audio connection has dropped for a second, so we'll try to connect him real quick.
Okay. Jen, in the meantime, a question came in for Mary Langley. Can we direct that question to Mary while you're reconnecting with Andre?
Sure, Mary's unmuted.
Mary, a question came in while you were presenting, and it reads, have you conducted trainings for community members on the use of Narcan, naloxone?
Our first training was with the first responders, and we are expanding our training for the community for certain community residents, community members during this year. So we will be expanding to residents, to the community.
Okay, thank you, Mary. I have some more questions that came in. Jen, should I proceed with them, or are you connecting up with Andre?
It looks like his IT folks are trying to help him reconnect, so, oh wait, maybe he did.
Can y'all hear me?
Do we have you?
I'm lit. Yeah, can y'all hear me okay?
Yeah, we can hear you again. Great.
All right. Well, good afternoon. So sorry for the technical delay. Excited to be a part of this webinar. Let's go to the next slide, please. I want to give you a little bit of background about Detroit Recovery Project. We became a nonprofit July of 2005. We are a peer-led, peer-ran, peer-driven organization, and we are an organization that provides prevention, treatment, and recovery certified by the state of Michigan. We are a CARF-accredited organization. Next slide, please. Where we are today, we have roughly about 50 employees. 90% of those individuals are individuals in long-term recovery. We have 3 sober homes, 21 one-bedroom apartments, a fleet of vans, 2 recovery centers. We provide probably 75% of our work is recovery support services, 10% is outpatient treatment, and 15% is prevention services. We serve on an average of about 500 individuals per month. Next slide. Just give you a little data around Detroit. We have about almost 72% African Americans. We have a high poverty rate, which is 37.7%. 1 out of every 2.6 residents are living in poverty. In the city of Detroit, we have almost 700,000 people, and almost half are living in poverty as well. How this compares to the rest of the state of Michigan, or the rest of our state poverty rate is 15.6%. Next slide. So I wanted to kind of share some of that past data around health disparities and poverty, which some of you all have already mentioned the linkages as relates to opioid addiction, particularly as it pertains to urban America and African Americans. But one of the things we've been able to do is build some very strong partnerships and collaborations with our universities, our provider network that consists of both prevention, treatment, and recovery. But with the opioid addiction in our region, partnering with University of Michigan Injury Prevention Center, we began to collect data around opioid overdose surveillance so that we can begin to target the areas where we have the most overdose as it relates to the zip code, whether east or west side of Detroit. Next slide, please. These are just some of our stakeholders. As you can see, we have prevention stakeholders, treatment stakeholders, community stakeholders, as well as our local funder. Next slide, please. And we have real-time data. For example, fatal overdose from April 1st, 2019 to June 15, 2019, we had 191 overdoses. 91 was African Americans and 100 were white. And you can notice that the males to female ratio was 124 males to 67 females. Next slide, please. Average age of opioid overdose was 42 years old. We had 20 blacks, 22 whites, 27 males, 15 females, and that's just within a 7-day period from June 2nd, 2019 to June 17, 2019. Next slide, please. And so what I've done in the slides is you'll notice that I kind of tailored the services related to the services that we provide, particularly as it pertains to prevention, treatment, and recovery. We do have a couple of prevention grants through Center for Substance Abuse Prevention and some local prevention funding too. And so we have one through our prevention funding. We have a coalition that we started several years ago called Love Detroit Youth Coalition. And we are also actively involved in some of the national campaigns that's taking place. I think it was already mentioned Prescription Drug Take Back Day, and we partner with the police department, schools, churches, as well as corporate and local businesses. We have Narcan is accessible at both of our recovery centers. Detroit is kind of broken off into the east or the west side, and so we have a recovery center in the heart of both sides of Detroit, east and west. High drug trafficking, prostitution, crime, homelessness, everything. We are right in what I call the belly of the beast. We also, we train our coalition members, and the coalition members have also trained their communities. We have trained the trainers on how to dispense naloxone. We also continue to do ongoing awareness campaigns around what the Good Samaritan Law consists of and how we need everybody to be actively involved in our prevention activities. Next slide, please. We also have treatment in-house, which we have an intensive outpatient treatment team, and all of them have received extensive training around medicated assistant treatment as well as medicated assistant recovery services, what we have known as the MARS training. And we've also established ongoing MOUs with existing MAT providers. Mostly, we have a very large group of methadone providers. I think we may have about 15,000 people who are on methadone in the city of Detroit. Buprenorphine, Suboxone, and Vivitrol are a fast-growing medicated assisted program in our state, but not so much in the Detroit area. But we are looking to expand that, move forward. And we're also looking at continuously adding and building on our recovery community volunteer base to be actively involved with those who have opioid addiction or use disorder. Next slide, please. And so we talk about recovery. Now we'll talk about some of the activities we have that's kind of occurring in our recovery program. One is we have a 12-step Fellowship Anonymous Support Group. That support group was established here in Detroit, targeting the methadone population, because people who were on methadone in Detroit felt a little ostracized from other 12-step communities, but we have had a 12-step fellowship support group that's really a support group that's more for any Medicaid-assisted treatment modality. But this group was founded here in the Detroit area, and we have it here at our recovery center twice a week, and it's growing by the days. We also have a lot of outreach that we do in high-density drug-infested communities right here in the city of Detroit. Right where our East Side location is housed, which is our East Side Health and Wellness Recovery Center, we're in the epicenter of prostitution, LGBTQ prostitution, and a whole lot of HIV and IV needle users, the whole shebang. And so we do a lot of outreach. Mobile outreach. We roll up in our recovery vans. Our recovery vans are really recognizable with pretty mural recovery positive words on our vans. And again, most of our team are people in recovery, so we don't mind. Our staff don't mind going up on the scroll, approaching the prostitute and saying, "Hey, would you like some help? Would you like to get some a rapid HIV test, or would you like to, or would you be interested in recovery?" Sometimes we got to meet the people where they are. So we're boots on the ground. We also facilitate naloxone trainings through our Recovery Training Institute. We have a training institute, a program that's funded through HRSA, where we provide, we were funded for a grant called Increasing Paraprofessional Workforce through trainings. And so we've trained on an average 250 individuals to become state certified recovery coaches. And part of that grant is also to particularly increase the workforce to address the opioid use disorder epidemic. And so that's an ongoing training that we have 3 weeks out the month. Next slide, please. We also have a CSAC grant, Building Communities of Recovery. We're just wrapping up our first year of that grant. So part of that grant funding is we're building a statewide effort to build on recovery communities or communities of recovery. But in the city of Detroit, we are also hosting quarterly town hall meetings to discuss strategies and resources addressing the opioid epidemic here in the Detroit community. Again, and this is through our recovery component, we're discussing the benefits of Narcan. We also have an advocacy coalition, which is called Real Michigan. That stands for Recovery, Education, Advocacy, and Leadership. And that's where most of our conversation is around having conversation with our local and statewide county elected officials, around health departments, as well as primary care. Next slide, please. These are just some upcoming pending strategies that we have in place that I think will help to curtail and build addressing the opioid epidemic in the African American community. One is Mike Bloomberg, the philanthropist, was recently in Detroit, where he pledged to give out $10 million to the state of Michigan to address the opioid epidemic. Well, he actually pledged $50 million nationally, but our state, he visited our state. Our state reached out to our office. His team actually visited our office, and we are expecting some funding this year that is going to assist us with addressing opioids. So I'm excited about that. Our health department and state has asked us to expand and develop a needle exchange program. So we do have that in the works, because we do know a lot of folks are actively using IV drug injection, and it's important that, you know, I know a lot of folks don't always agree with it, but It does reduce hepatitis and HIV, which is some other comorbid challenges that we have here in our community. We're also expanding our recovery program to providing some Vivitrol. We're building a medical center here at our recovery center. We have about 15,000 square feet, two levels to our recovery center, and so we're building an on-site medical office, which we anticipate will be up and ready by October 1st. We also have additional funding to house a internal medicine as well as a nurse practitioner. We're just awaiting on our licensures to become a MAT provider. Next slide, please. When we talk about collaborative opportunities, I think it's only normal to build relationships with your local universities. We have a strong partnership with University of Michigan School of Social Works, School of Public Health, as well as the Injury Prevention Center Department. And by the way, University of Michigan was ranked #1 public school in the United States last week, so U of M. Also, Wayne State University is another large university in our Detroit area, and they have a very large School of Social Work as well as School of Nursing program. So we have strong ties with those entities as well. And a lot of times when you have strong collaborative relationships, I know the previous presenter talked about in-kind, but sometimes that in-kind can go both ways and result into a very long-term positive relationship. And these are institutions we've had relationships with for several years. Our state of Michigan changed their it used to be drug control policy. They changed their name to Office of Recovery Oriented Sensitive Care. So we have a very strong relationship with our state office as well. Next slide, please. Next slide, please. Also, Detroit Wayne Mental Health Authority, that's our local funding source where the money comes from SAMHSA to the state and to the county, which is Detroit Wayne Mental Health Authority. They oversee roughly $700 million between Black Grant, Medicaid, treating SUD as well as mental health services. Strong relationship with that department, which you know is very important. We also have a strong relationship with Detroit Wayne Health Authority. Excuse that typo in the word psychiatry, but they handle about 40 intern students who are pursuing becoming medical doctors or psychiatrists. And they place these resident students throughout the state of Michigan, and we have a rotation site where they are coming on site. They're learning about behavioral health. They're interacting with our recovery coaches, and vice versa. They are training our recovery coaches on basic questions and basic symptoms around hypertension, high cholesterol, and really trying to work towards integrating or having a more integrated health and wellness program with our behavioral health program. We have strong partnerships with our local Detroit Community Health Connection, which is a FKC, and they have about 6 locations throughout the city of Detroit, one of the largest fairly qualified health centers. And so one of the strategies we are offering is we provide expert services at all 6 sites. Next slide, please. Just again, strong relationships, strong partnerships can also turn into resources. So we work closely with the City of Detroit Health Department, our Prevention, Treatment, and Recovery Network, as well as law enforcement, our Department of Corrections, and other primary health care centers. Next slide, please. We work with our local mayor's office, city council, our county executive, our county commissioners, our state legislature, our governors, our House of Representatives, other health servicing organizations, as well as SAMHSA, CSAP, and CSAP, who we love. Mark, next slide, please. I call this the free or inexpensive low-hanging fruit tree. Next slide, please. Adult, juvenile, drug courts, I think, are low-hanging fruit opportunities for us to begin to build rapports, because a lot of the court systems are inundated with a growing system because of the opioid epidemic, and a lot of times they are looking for outside help. They are looking for programs to support their people. Over the course of the last few years, a lot of judges said that they realize that we cannot lock our way up. We can't lock our way up, or we can't lock people up to solve this problem, but we have to treat the problem and build more partnerships. We've helped write grants, SAMHSA grants with juvenile drug court, got them funded, and had recovery coaches who were actively part of the juvenile drug court, recovery coaches who are actively involved in adult drug court, mental health drug court, Salvation Army, a lot of homeless centers where people kind of migrate in and out of these homeless centers. We also have opioid addiction. We were instrumental in increasing drug drop-off bins in our police stations as well as community centers. And again, local law enforcement. Law enforcement are seeking to build strong relationships with community folks, because law enforcement, and I'm talking about the local police as well as our county sheriffs, are all and have been very, very open to building strong relationships to help people get the help they need versus locking them up. Next slide, please. These are just some of the evidence-based best practices that we've employed in our recovery centers. Medicated assisted recovery services, motivational enhancement therapy, seeking safety, cognitive behavior therapy, motivational interviewing, certified recovery coaches, 12-step meetings, and the recovery support service model that builds on individuals' emotional, companionship, informational, and instrumental areas of social support. Next slide, please. Our slogan is doing it together. Thank you.
Thank you very much, Andre. That was terrific. And we have a couple questions for you before you sign off. We have a few minutes for questions. We've had a number of questions come in. I'm going to start with Andre because he just came in. Is the SOS OD tracking system that you mentioned in one of your early slides part of a pre-existing data reporting system that was already used by the EMS and hospitals?
I think what happened is they created a database, and yeah, it's a partnership between the EMS and the hospitals, and they plug it into this database, and that's how we're able to have real-time data.
Great. Okay. And the other question is, you talked a lot about recovery outreach.
Yes.
If somebody want to replicate what you were talking about in terms of really reaching out to people in really tough situations, how would they start?
Well, I think the first thing would be is probably come reach out to us. We do offer a number of trainings around how to outreach into your community because we don't want to set people up for harm. You know, when you're in these high drug-infested areas, you got to have the right team to go out. And you want to make sure you have a team of folks who are not intimidated of going out in these communities with strong, or what I would say, long-term recovery, but also very comfortable in their own skin with communicating. But sometimes it can be a little challenging, but sometimes you can be very surprised at people's responses.
Great. Thanks very much. Dr. Mancini, question for you. What are some strategies for working with parents and youth to prevent or reduce opioid misuse and addiction?
Thank you, Lark. I like to focus on 3 items of language, workforce, and evidence-based and promising practices. So one of the most successful strategies we have are our parent education sessions, which are held in person, and the items that we usually have success with include providing food and child care. And they became one of our biggest strategies, and we ended up having record attendance at each one of these. And the way we did it is partnering with restaurants that would donate or significantly reduce discount food and volunteers that would provide childcare during the sessions. But what really did it is our presenters were bilingual and bicultural. What that meant is that they understood the culture, they understood how to address the issues that may be sensitive for some members of the audience, but issues that needed to be discussed in this field, like sex, drugs, foul language, and other items that are part of our day-to-day work. The presentations were also professionally developed using PowerPoint and making sure that the community felt respected. If we were going to hand out material, that it was professionally developed material, that it wasn't anything that could have looked like it was rushed or cheaply made. And we wanted to make sure that the community felt respected. And then the sessions were held in the evenings when members of the community could attend. And the workforce part was key because we had to recruit people that really were dedicated to wanting to do this. So for us to ensure the attendance, we couldn't just send a piece of paper home with the youth or through the school. So we would call the parents and tell them what the event was going to be about, make that personal invitation and try and engage them that way and get their commitment to come and at least check it out. And always in our community, family continues to be extremely important, and they were so hungry for this type of information that it was almost a no-brainer for them to show up, and it was standing room only. Thank you.
That's terrific. That's terrific. Thank you very much. We have a lot of questions. I'm not sure we're going to be able to squeeze all these in. I do want to respond to a comment that came in. People are asking for the contact information to connect with presenters after the webinar. So this webinar will be archived, and we'll let you know the location that it will be archived at. And emails will be included in the archive material. So if I can squeeze another question in very quickly, Ricardo, often clients from these populations are reluctant to engage in therapeutic services. What's your best suggestions about how to encourage engagement in treatment?
Letting just like recovery regarding with my project. I think there is and sort of
you're breaking up a little bit, Ricardo. You're breaking up a little bit.
Sorry. Can you hear me now?
Yes.
Yeah. Okay. So I think the longer answer to this question is we need to try to take a step back and determine why aren't individuals engaged in treatment services or therapy services. And I think for my answer, I'm going to focus on treatment. I think, in the minority communities, there's a misunderstanding of what treatment is. There's a lot of myths. And we need to dispel these myths. I approach my patients with is no different than having hypertension or diabetes, and I think we need to, take that approach. However, medication is, I'll be.
You're breaking up a little bit.
Sorry. Hello.
Okay.
Can you hear me?
You have 30 seconds.
Yeah. So we need to, dispel these myths. We need to address mental health services. We need to address social determinants of health, and we need to, message this in the communities. In addition, we need to decrease the barriers to access. I think we're lucky here. Morphine is covered by, Medicaid, and I think that makes it easier for individuals to engage in treatment.
Okay, great. Thank you very much. I'm going to have to go on to the next slide. I'm sorry we can't answer all the questions that came in. Next slide, please. So I want to remind participants on this call to complete the feedback form, which you will get at the close of the webinar. I want to mention that the webinar materials, the slides, and the recording will be archived by September 15th on the National Network to Eliminate Disparities in Behavioral Health in that website. So I suggest you take that website down, www.nned.net. Suggest you write that down, www.nned.net. Will also be some links to resources, some of which you see there, and there will be another page of resources relevant to the topic of this particular webinar. I want to very much thank our presenters. They clearly have deep expertise and commitment and tremendous work that they're doing in the African American and Latino Hispanic communities. I want to thank you so much for the tremendous amount of information you gave us today. I want to thank all the participants who joined, and we're sorry we didn't get to all the questions that you all submitted. We'll figure out how to do that. And I also want to thank my staff, Rosalind Holliday Moore and Victoria Chow. They had the biggest hand in putting this webinar together, and Amy and Jen, our contractors. So this concludes the webinar. Again, it will be archived with the PowerPoint, so we suggest you look for that after September 15th. And so that concludes the webinar for this afternoon. Thank you very much for joining us.